we'll start with patients with special challenges. So last class we talked about pediatrics and we talked about geriatrics. This is going to be some of both and then a little bit extra. It'll be those types where we have to think about extra things when it comes to these patients. So this talks about chronic diseases. That affects a lot of different things. Chronic disease doesn't just necessarily mean a specific disease. It could be that they're living with being deaf, visual impairments, autism, mental retardation, you name it. There's a lot of different things out there that can impair the normal day-to-day function of our patients. Some of these disease processes end up affecting parts of the respiratory system, circulatory system. They need extra medications daily. So you might see some that have that mechanical vent. They may be on a trach vent. They may have IV pumps, diabetic pumps, pain pumps, things like that. So we need to be aware of those and always ask patients about them. Don't be distracted by the equipment. Obviously, if they have it, you need to make a note of it, but don't let that cause you to panic. For one, most of the time you can ask these patients, hey, what does that do? For one, they'll know what it is. They're usually far more educated on it than we are. They have to be. They live with it every day. And again, focus on the patient. Just because they have a pain pump doesn't mean we have to forget the fact that they called for difficulty breathing for something completely unrelated to their disability, medication, pump, trach, things like that. Again, we treat the patient, not the machines. So we'll talk about intellectual disabilities, developmental disabilities, or insufficient development. A lot of times this includes not only intellectual stuff, but their hearing and vision impairments. They may end up having hearing loss, or they may end up wearing glasses or not being able to see at all. With these patients, sometimes we have to kind of slow down how we talk to them, make sure that they understand what we're doing, make sure they understand the words we're telling them, what things mean. Again, like we talked about way back when we talked about definitions and stuff, these people, we don't need to use large words that we use talking to doctors or nurses. Just like with regular patients, we need to make sure that they understand these things. If that means we tell them, hey, your lungs aren't working right, then that may be the case. At the same time, they may appear to be an adult but function at the level of a child. So change your assessment plan, your way of speaking, your sample history gathering. Change it accordingly. Again, most of these people can function at home just fine. They also may have a caregiver with them. With that, again, when we talk about sample history, gather that from bystanders on scene, people who know them. Don't just leave it to just that specific person, because they do develop a little bit slower, like it says. So when it's slightly impaired and it's that slow to understand or limited vocabulary, like we just talked about, again, talk to them, respect them. Don't necessarily dumb things down, treating them like they're stupid, because they're not. They just don't, things don't come to them as naturally as it does to us. They may have a little bit of behavior issues. They may act like a child. Again, that's that developmental delay. If it does appear to be too severe that we can't communicate to them appropriately, or they're not going to listen to what we have to say, or that they don't understand it, again, talk to the caregiver that's there, or operate under the implied consent where a normal functioning adult would want help. So like we just said, rely on patients' family members for information. Again, these patients, kind of like autism, they don't like things being changed. So we need to be very cautious when we go to assess them. Just like how we start with children feet first up until they're 6, we need to be aware that these patients may not enjoy us getting up close and personal. Again, ask the family how to approach them. How best do we do this? But they are normal functioning people. They have the same kind of systems we do. They're susceptible to the same diseases, illnesses, trauma as we are. So just because we can't communicate with them well doesn't mean they won't have the same problems. They may not be able to tell us, well, I'm having night sweats and difficulty breathing at night, and I've had extreme weight loss. Well, I mean, most of us can tell you that, and we figure out, oh, okay, it's probably TB. These patients may not know that. So just be aware that with these patients, we're going to have to dig a little bit deeper. Autism right here. Social interaction with these people is really difficult. Again, we need to ask the family how best to approach them. Take it slow. This isn't going to be something that happens incredibly fast. See what kind of triggers they have. They may not want to be touched in any way, shape, or form, or they may not care. It just depends on their spectrum. They may be able to talk, they may not be. A lot of these are going to vary depending on the patient you see. Again, I can't stress enough, family, bystanders, caregivers are going to be your best bet for these patients. Oh, excuse me. They may not be able to understand us when we're using nonverbal communication. So if we kind of point to the stretcher, they may not quite get that. We may have to explain to them, okay, I need you to stand up. Once they stand up, then move to the next process. I need you to walk over to this stretcher for me, and then I need you to sit down. That way, they've got one focus, and that's all they have to worry about for that instant. Once they get there, then we give them the next task. And just be aware that males 5 times more likely than females to have autism. So if you go out to a altered patient or a combative patient or unknown problem, and they say, man, this dude's acting weird, nobody knows who he is, kind of keep that in the back burner. They may possibly be autistic. So Down syndrome, this is the one that comes from the chromosome defect when we're born, before we're born, excuse me. Mild to severe impairment. So these are the patients that we're going to have to, again, talk too slow, make sure they understand. Okay, they'll have these ones you'll be able to kind of pick out a little bit easier than autism because they do have some physical abnormalities that come with it. They have that rounded head, wide set eyes, they've got a bigger tongue. Most of the time you'll be able to see them and know, okay, this patient has Down syndrome. They're at far more of a risk for problems, especially heart conditions. They'll also go deaf and have sight issues way more often. When we go to do airway management with these patients, because of that big old tongue, we have a lot more of an issue trying to secure the airway itself. They have a smaller mouth, smaller nose, so those NPAs and OPAs that we normally use for a patient of that size may not cut it. We may have to drop it down a size. May not be able to get as good a seal one-handed or one rescuer seal. You may have to use 2 people. Like it says, that jaw thrust that we normally use for trauma patients may be far more effective with them. Again, whatever we can use to appropriately ventilate the patient and keep them oxygenated. Seizures, same thing. We're going to take care of them just the same. That Atlanta axial joint up there in the upper body, it's a lot more unstable. So they run a higher risk of having like spinal cord injuries, paralyzation, difficulty walking, all that due to that unstable joint. So like it says, if you're uncomfortable, that's okay. They are a little bit harder to deal with. Okay, we all kind of get that sense of apprehension, like, oh man, this might be a little bit harder. I don't know if I'm going to get the information I need. That's okay. Perfectly normal. We just have to work through that. You know, approach them in a calm, friendly manner, just like any other patient. We're going to introduce ourselves, introduce our team. You know, hey, my name is Sean. I work with UT Health EMS. This is Michael. We're here to help you. Can you tell me what's wrong? You know, same thing we're going to do with every other patient. Just with this type of patient, it will be a little bit slower. Normally, we can get out 3 or 4 questions in the span of 30 seconds. You know, hey, how are you doing? What happened? Can you tell me when this happened, and are you hurting anywhere? Each of those questions will probably have to take longer with these guys. Hey, how are you? Let them answer, and then what's hurting? Let them answer again, and then how long has this been hurting for? That way we don't overload them. They don't kind of shut down on us, get overwhelmed. Just take it slow. Explain what we're going to do to them, just like we do with kids, elderly folks, anybody really. Tell them, hey, I'm fixing to start an IV on you. It's going to hurt for a second. Or I'm fixing to put this mask on you so it can give you oxygen and help you breathe better. We're going to do these very slowly, very purposefully. At the same time, they may panic anyway. Just keep an eye out for it. We don't want to make things worse, just like any other patient. And again, since they already have that large tongue and that narrower airway, kind of like a child, we don't want to aggravate any other conditions. Main thing, treat them like normal people as much as we can. Let them know that we're there to help them. Okay? We want to establish that trust. We want to be able to get them to talk to us and tell us what's going on, because our job being there is to, again, take care of them and treat them. So brain injuries, there can be anything from brain injury at birth, traumatic brain injury from a car wreck, baseball bat to the head, you name it. Some of these patients can be extremely difficult to deal with because they've had an alteration of their entire sense of self, for lack of a better word. They'll have a complete behavior change. Somebody that normally was cool, calm, collected is now angry all the time, possibly violent. Need to find out from the family, hey, are they acting normal? They say, well, no, this has happened before, or they're normally kind of aggravated after they had that accident, but this is worse. Always find out what their baseline is. That, for one, we can tell the hospital when we get there. And with these ones, again, just like everybody else, I feel like it's kind of beating a dead horse. We're going to explain stuff to them. We're going to try and calm them down, reassure them that, yes, we are here to help. We're not here to make things worse. Treat them with respect. Just because they had a brain injury and now they're kind of a butthead doesn't mean we treat them any different. Okay, it makes it a little bit more difficult, sure, but we've all dealt with difficult people in our life. This is no different. So visual impairment can mean anything. It can be from having poor eyesight to being born blind to being colorblind, glaucoma, cataract, trauma. All of those are different kind of causes for visual impairment. It just depends on what is truly affected. Do they have that, central vision? Do they have tunnel vision? Are they able to see in their peripherals? Can they see us coming from the side? Do they see defined shapes very well? Do they see light, dark? Do they see color? Do they have silhouettes? What is their normal? And that's something that only they can tell us themselves. That being said, when we first get on scene, we may not know that they are visually impaired. They may be sitting down waiting for you to get there, and you come in and say, well, have you seen, let me take a look at your leg. Is it the right or left one? And they say, I don't know, I'm blind, something like that. Just be aware that if they're not tracking you, if they're not responding to when you walk in the room, that may be the case, is that they just can't see. That being said, just like when we knock on any door going into a house, make sure they know we're coming. Not only because they might be blind, but they may also have a firearm pointed at you. So always let them know, hey, this is, EMS, we're coming in. Where are you at? Where are you located? That way we can, for one, find them. They make sure they know we're EMS so we don't get shot. And that way they can tell us, for one, where they're at. They can shout, I'm here in the back corner of the farthest bedroom from the front door. If we have visual aids, or if they need visual aids, hey, I need my glasses. I just woke up. They're on the table. Grab them for them. Make it easier for us. They also may be disoriented, especially if, excuse me, if they're not at the residence. Okay. If we help pick them up from the floor and turn them around, that may be just enough to set them off where they're not used to how this certain thing feels or where they're located in their room. With these patients, even more so than the other ones, we need to talk to them. For one, they can't see anything. So if we're going to tell them, hey, I'm fixing to start an IV on you, well, they may understand that, but, we can actually touch on their arm. Okay, I'm going to go right here, or I'm going to put a mask on you, and it's going to be around your head. You kind of put your hands around their head to show them this is what it's going to be. Remember, we're patient advocates. That means we need to take care of them, not just treat their vital signs, treat their initial problem, but treat them like people, take care of them. That's what we all should be here for, right? So when we take these visually impaired folks, if they've got a walker, if they've got a cane, absolutely take it. Okay, that is their assistant device. Okay, they may not be able to walk, period, without it. For one, a cane lets them find where they're able to walk, if they're going to find any obstacles or anything like that. If they have a service animal, we need to make arrangements for it. Don't necessarily transport it in the ambulance. The hospital gets kind of upset with that. Try to, use law enforcement, family members on scene, caregivers, and get that animal taken care of for now. But we always want to make sure we're not like manhandle. We don't want to shove them or throw them on the stretcher. We want to be gentle, okay? They don't know what's going on. They called us for help. We don't need to be rude about it. We don't need to be a jerk. Gently kind of get your arm underneath theirs, grab their hand or their wrist gently, and kind of steer them towards the stretcher. If we're going to walk near a chair or something on the floor, let them know, okay, here in another step, you're going to feel your foot touch this. I need you to step over it. Don't just sit there and watch them trip over that thing. All right. So hearing impairment, again, all these can range from just having a little bit of hearing loss to complete total deafness. Like we talked about last class, geriatric patients, things are starting to wear out a little bit. So older folks have some hearing loss. Okay, a lot of older folks end up having that major hearing loss where they can't hear us. Some clues as to if they're hearing impaired. Well, for one, if they're screaming at us or if we're talking to them and they can't even hear us. If you notice that they have hearing aids on or that there are hearing aids on the table. If you notice that the TV is incredibly loud. If you hear the phone ring but the light blinks on and off multiple times while it's ringing. All those things can kind of key you in on, okay, maybe they have a hearing issue. If they have hearing aids, definitely find them. It's always easier to do it that way than having to scream at them. But make sure you're facing them. A lot of them can lip read. So if you talk to them correctly and enunciate and pronounce your words right, they'll understand you anyways. Like I said, position yourself 18 inches directly in front of the patient. Right now, thanks to coronavirus, probably not going to necessarily do that. Probably need to be 6 feet away if we can, but you want to make sure that they can see your face and see how your mouth is moving. So some of us who sit there and talk or mumble or don't move our mouths very well, this is the perfect time to start getting used to doing and improving that. So like I said, don't speak louder. Try lowering the pitch of your voice. And if you know anybody that knows American Sign Language, jump on it. See if they will teach you some. That stuff is amazing. Okay, it always ends up helping out. You can also sit there and use what's called the reverse stethoscope trick. You can put the earpieces of your stethoscope in their ear, and you can kind of speak on that diaphragm of the stethoscope, and that might help them hear you. Just make sure you
Hey, Sean.
Yes.
There's a lot of YouTube videos that will teach you sign language that you want to know. Like you could type in a word and it'll teach you that sign language. I use it to learn sign language with my youngest, well, actually my oldest grandson who's nonverbal. So that's an idea if somebody wants to just go to YouTube and look it up. They have a lot of them on there.
Yeah, perfect. Like I said, it's definitely a skill that's sorely needed. Because again, when we encounter folks, most of the time we don't see patients that are just absolutely 100% normal. Okay, we've got a lot of nursing homes, we've got a lot of assisted living facilities. Tyler and the surrounding areas in general have a lot of older, older patient base. So if you can learn at least even some, where the pain is, are you hurt, things like that, that can help you at least kind of connect to that patient. We're not necessarily eliminating the need to talk to them or communicate, just to kind of put them at ease. If all else fails, if you can't get them to talk to you, if they're not hearing you, their hearing aids aren't available, you don't know sign language, the stethoscope's broke, we have pen and paper. Use what you have available. Just make sure that when you're doing this stuff, that only one of you is talking to the patient. We don't want to try and confuse them any more than they already are. Especially if they have hearing aids, they may be getting two different conversations. We only want them to focus on whoever is getting the information. All right, so hearing aids, like it says, they make sounds louder. There's quite a few different ones. You've got behind the ear, in the canal. There's now cochlear implants. But the devices should fit correctly. So if you hear that whistling, you may have to help them push it in a little bit. Again, just ask them about it. Can I help you with this? Or I hear whistling. They may not hear it still, okay, because it may not be pushed in enough. So there's a little bit better picture of a handful of them. Cerebral palsy. So it's disorders characterized by poor controlled body movement. The movement of the body, not necessarily seizures, but they're not able to coordinate themselves very well. Sometimes they can't run right. Sometimes they can't get up off the couch very well or stand up straight. Again, you may just have to ask the family members about this. Sometimes they'll have developmental delays. They may have issues where they have constant seizures, may have facilitated some other illnesses. Again, kind of keep an eye out on their airway. And they never assume that they're disabled or that they're mentally incapable of talking to you. People have cerebral palsy and function fairly well for their life. It's not as crippling as it could be. So just always ask, hey, does this patient have cerebral palsy? How bad is it? What does it normally affect? How best do I approach them? Because again, family will be able to tell you they experience it daily. So with that poor body movement and lack of coordination, those limbs end up being underdeveloped. So they run the risk of tripping, falling, injuring themselves. Again, take care of the patient themselves, not just the disease process or what we think may be wrong. Pad the stretcher if we have to use a pillow, we have to use a blanket. Don't put their, if their legs bent up in an odd angle and they're not complaining and they're not hurting, don't try and force it back into a normal position. That may be what their position is. And just like with the visually impaired, take their walker. If we can, take their wheelchair. That being said, wheelchairs are difficult to secure in an ambulance. So if we can, one thing I would say just on a personal note, see if the family will be able to take it themselves. Most of the time, somebody will be going up to the hospital with them. They may not be able to communicate well. And again, it's always important to talk to the family about it because we don't want to have a big projectile in the back of the ambulance in case of wrecks. But if nobody else is there, we do what we need to and take that stuff. Right, so there's a little picture for you, spina bifida. Spinal column has not closed properly. Okay, so it's exposed out there to the world. They can close it up, but they will end up with some type of spinal damage. Again, these patients, either their parents or they themselves, will know that they had spina bifida. There's a couple different things that go along with it. Obviously, partial or full paralysis of the lower extremities. It's kind of a given. Like we said, they've got to surgically close it up. They usually end up with some kind of damage from that. Hydrocephalus, they'll have some fluid on the brain. Loss of bowel or bladder control. Again, it depends on where that surgery was done. How far down was their spine exposed? And they may have a very large latex allergy. So thankfully, most of the gloves we use, we have nitrile. But again, always ask, are you allergic to anything? If they're allergic to latex, they will definitely let you know. But with these patients, we need to ask either them or their caregivers, hey, how best do we move this patient to the stretcher? Because again, they deal with it every day. They're used to it. They're experts in their own care. Use that to our advantage. So paralysis, we know by definition, is the inability to voluntarily move those body parts. Okay, if they're paralyzed, it's not moving. What can cause that? All kinds of things, between trauma, medical issues. Like I said, spina bifida is one. They could have had a traumatic car wreck that severed the spinal column at, like, say C7. It just depends. Okay, there's multiple different issues that cause that. Depending on where that injury was or damage is, they may have normal sensation up to that point, or they may not have any at all. These patients can be on a ventilator. Again, depending on where that injury took place, they will no longer have that diaphragm muscle working. Little, I don't know, phrase, I guess you could call it. C1 through 5, stay alive. Usually if you damaged anything C5 or above, you ran the risk of losing that ability to use the diaphragm. You would stop your ability to breathe. So most time with those folks that have that high cervical injury will be on a ventilator. There's no ifs, ands, or buts with it. That being said, they may, if they do have some control, they may have difficulty swallowing. They may have to be prepared to suction. And with all this goes some specialized equipment. If they don't have bladder control, they're probably going to have a catheter. They may even have a colostomy bag. If they can't breathe, they may have a trach. They may have feeding tubes. It just depends on what kind of damage they originally had and how they have adjusted to it, or how doctors have corrected those situations. Again, same thing with the other ones. Ask how best to move them. Just because they're paralyzed doesn't mean we want to break their legs or break their arms. We want to avoid that kind of stuff. Even if they can't feel it, it's still going to cause issues. So again, hammering it home, we're patient advocates. Bariatric patients, obesity, somebody who has excessive body fat, 30% over their ideal body weight. Severe obesity is 2 to 3 times that. By definition, being, for lack of a better word, being fat is an imbalance between calories consumed and calories used. You possibly eat a lot of food and don't do a lot of exercise. You can have a family history of it. You can be genetically predisposed. Your metabolism probably is off, not working near as well. And with that come other health problems. Again, we have heart health, diabetes, strokes. Those are probably 3 of the big things for that when we talk about obesity. So be aware, if they're a bigger person, they may have some of those associated issues. We need to ask patient history. When we talk about these folks, about treating them, we may need extra help. It's not a slam at them. Just most of us are not used to lifting 300, 400, 500, 600 pounds, whether we're on our own or with a partner. We want to make sure we don't injure them or ourselves. So we always need to call for additional resources. That being said, we got to treat them with respect. Give them dignity. Okay, nothing's worse than you sitting there trying to take care of them and your partner's in the background snickering. Look at this big old chunky boy. Don't do stuff like that. Okay, we're professionals. We need to act like it. Again, same with other patients. Ask them how best to move them. They may know the best way. Well, the last time they came in here, they used the Titan tarp and they rolled me to this side, and that worked really well. Okay. Again, they're used to themselves. They're used to their condition. They probably have better information for us. Don't try to lift them by one limb. Again, if you're pulling hard on it, you could cause damage. You could cause an injury. Coordinate with each other. Lift on 3. 1, 2, 3, lift. Make sure everybody's on the same page. That way we don't cause any injuries, again, to the patient or ourselves. With these folks, You got to look for those pressure points or pinch points. Okay, most time they don't fit quite well on the stretcher. We may not be able to lift the rails up, or if we did, we'd pinch the tar out of them. Okay, same time they need to sit up. Most of these patients will not be laying down flat. They can't. That weight can't. Their lungs can't support it. When we get in there and we start talking to the patient, it's always good while one of us is gathering the information for our partner or first responders that are there to look around and figure out what's going to be the best way to take this patient out of here. How safely can we do this? And if we can, let the facility know, or the hospital, as early as we can, hey, we're bringing you this patient. I just want to advise you they're 750 pounds. That way they have the appropriately sized bed when we get there, and they have the additional help necessary to move the patient or take care of them. Trach tubes. This provides a path from the neck to the trachea, so this is an airway device. Okay, it bypasses the nose and mouth, so they don't need to breathe out of their nose or their mouth. It's right there from their neck. These can happen from birth defects, spinal injuries, disease processes may have dictated that they needed to have this device placed. With this, they're not necessarily used to expelling stuff out, so that mucus does accumulate, or they may get something stuck or lodged in it. When we think about that, we need to think about what's called the dope mnemonic. Was it displacement, obstruction? Oh, what was the P? I forgot what the P is. And then placement, I believe, and then equipment. All of these help us figure out if there's something truly wrong with it. P is the pneumothorax. I apologize. It's been a long day. But that pneumothorax is where we have the increased pressure in the chest or the popped lung. So displacement, whether or not that trach tube has been pushed up or pushed down, and now it's not actually incorrectly. The obstruction, did it get plugged up by mucus? Is there a piece of food particle? Did they shove something in there? Pneumo, did they pop a lung? Did they have something cause that? Or equipment, is the vent even working? Because most of these folks are obviously on vents. Turn it off, turn it back on, disconnect it for a second, see if it's working. If all else fails, you put our own BVM on there and bag them. Because these folks are pretty much similar to anything else we deal with. If they're breathing on the vent just fine, great. If we have to suction them, again, we suction for no more than 10 to 15 seconds. The only difference is, again, they're not using their nose or their mouth. It's coming out of their neck. So kind of tying into those trach patients, like we said, they're on ventilators a lot. High definition, a mechanical ventilator is something, a device used when a patient cannot breathe. If it messes up, we take them off the ventilator, put a trach collar on them, and then ventilate and transport. Fairly simple, but it's important. Possibly a test question. So just remember, if the thing's not working and you look at them and they look like they're in distress or their heart rate's starting to go down and down and down, take them off the ventilator and bag them yourself. Okay, then it just turns into, again, rescue breathing like we taught before. Apnea monitors. Apnea, we know, is the lack of breathing, no breath, right? It's used a lot of times for infants who were born premature. they have GERD, family history of SIDS. You remember that experienced a life-threatening event is where they stopped breathing and they were able to be resuscitated. Learned that in the last couple classes. So if the thing starts going off, it means it's detected that they are no longer breathing. Most of the time, the family is aware of how this thing works. Ask them, how many times has this gone off before? Does this go off every night? How long does it last? Are they easily aroused or agitated, resuscitated, whichever word you want to use? We just need to know if when this goes off and they start messing with them, how quickly do they start breathing again? Most time you'll only see it up to 2 months. Definitely bring it with you, okay? Because the hospital may be able to gather the data from the device itself. Some of them transmit wirelessly. Some of them, if they're still using them, I don't know if they do anymore, they transmit over the phone. So always take that stuff with you. Pacemakers. Most of us know about pacemakers. You probably have seen one or two family members, friends, coworkers, acquaintances, patients that have had them. They're implanted underneath the skin, kind of up there by the shoulder a little bit, the collarbone. Most of the time you can see a fairly defined little square. Some of them do come with that defibrillator, so we need to be aware of that. Main thing is, don't ever place the AED pads or the defibrillator pads on top of it. Again, we learned that in BLS class. We're going to move it over to the side of it. It's always important for us to get the information about what type of pacemaker it is. Ideally, you want to know what type it is, when it was implanted, who did it, which cardiologist was it, what hospital they had it done at. That way we can get them to that specific place where they're familiar with that patient, their history, and the device itself. Left ventricular assist devices, LVADs. These ones are pretty neat. They take over the function of either one or both of the ventricles. Most time folks are in need of a heart transplant when they get put on this. This basically becomes their heart. The really cool thing about these folks, you may not feel a pulse at all. You may have a patient that is 100% alert and talking to you without a pulse. Really neat, really cool, but can freak you out at the same time. With these, we're just providing them the support to it. Ask them what they need. If they're having pain, treat the symptoms. If they're having difficulty breathing, work with that. Again, caregivers, medical control, those are resources for us. If you have our protocol app, we do have information on LVADs in there. Because some devices, depending on which one it is, you may not be able to do CPR. You may have to use a hand pump. You may not be able to give epinephrine during a cardiac arrest. That's a little bit more in depth than we need to go, but there's a lot of information out there, and there's quite a few different devices like this. Again, just like with the other patient, with the pacemaker, find out where they were going, which hospital they normally go to, what their cardiologist is, and get them to that facility. Always important that the person who is used to that patient and their problems and devices is the one taking care of them. External defibrillator vests, kind of like a built-in pacemaker, a automatic defibrillator, except it's on the outside. Okay, it's a vest worn by the patient under his clothes. Again, it's attached to a monitor that detects if their heart goes into a fatal rhythm or a shockable rhythm, and then it delivers said shock. if these patients are in cardiac arrest, we're going to keep that vest on. Okay, because again, it's detecting if there's a rhythm or not that it can shock. Now, if it interferes with your compressions, then yes, you would obviously have to take it off, but most of them do not. Central line, central venous catheter. This catheter's got its tip placed in the vena cava. Okay, most home care patients have these, like if they're being treated as like hospice patient or cancer, you'll see these types of devices more often. Again, common problems are it can get infected, it can get clogged, it may be misused. Unfortunately, some of these patients can actually try and use that for drug abuse. It's not very often, but it is out there. So there's a little bit better picture of it. Again, it looks like there's a couple tubes on there, so when you see these, it's fairly obvious what they are. Again, if they're complaining of chest pain, if they're have a fever, possibly look like they're septic, low blood pressure, high heart rate, double check the insertion site. Make sure that it's not infected. G-tubes. Okay. G-tubes are gastronomy tubes. They're placed in the stomach. This is for patients who can't eat, they can't use their mouth. This is how they get nutrition and medications. A lot of times you'll see these again in nursing home patients. One of the common things you encounter is that they get pulled out. Okay. And that happens. For one, we need to stop whatever is going through that G-tube. Okay, because it's now no longer where it's supposed to be. We could be putting food, medication into the abdominal cavity. So once we stop that, again, our primary assessment, secondary assessments are mostly focused on this. We're looking for if there's any signs and symptoms of tenderness, redness of the belly, distension, rigidity, pain, things like that. Because they may have possibly had some bleeding from it. When these get pulled out, if they're completely pulled out, always ask to take that with you. A lot of times doctors will want to see it at the hospital. That way they can size the new one appropriately and get it ready to go. These people with G-tubes, increased risk of aspiration. Again, it might backflow, especially if these patients lay down normally. Again, they're not used to using their mouth anymore. They may have a buildup of mucus. So always be prepared for suction. If you go in there and you hear gurgling, they sound like they're drowning, pull that suction out and get to work. Like I said, patients that are telling you that they have difficulty breathing or that you see they're in respiratory distress, put them on the right side and keep their head up. So shunts, we talked about shunts a little bit before. Didn't really go too into detail with it. Most time this is for neurologic issues, okay, whether they have a buildup of cerebrospinal fluid. So you've got your ventricular peritoneum shunt and your ventricular atrium shunt. Okay. So the peritoneum one drains the CSF from the ventricles of the brain down into the peritoneum of the abdomen. So it takes it all the way from the top to the belly. And then the atrium shunt, if you remember our anatomy from the heart, takes that fluid and places it into the right atrium. Most of these patients are going to tell you, probably when you start out talking to them, that they have a shunt. But if they don't, you palpate, kind of look behind their ear. If you feel that kind of fluid back there, you'll know that that's where the shunt is. Like I said, blocked shunts, infected shunts cause changes in the mental status and could cause respiratory arrest. Again, because there may be a buildup of that fluid, maybe pressing on the brain itself, causing those issues. So if they tell you, well, they had this shunt placed 3 weeks ago, and now they have a high fever, not making sense, breathing incredibly fast, blood pressure's low, may start looking into, okay, they're possibly infected. Signs of distress for this, again, signs of distress in any patient. If they're having difficulty breathing, signs and symptoms of shock, low blood pressure, high heart rate, and fever. Kind of be aware of all those kind of red flags for this. Vagus nerve stimulators, these are for the seizures. Okay, so most of the times seizures are taken care of with medication, like Dilantin, Depakote, Valium. We have Versed on the truck. For those patients that this does not work for, they try to use this stimulator. So our vagus nerve, when we talk about patients who vagal down, this is the nerve we're talking about. It kind of goes along the side of your neck to your heart. What this can do is drop your heart rate down and drop your blood pressure. So when these patients have seizures, it kind of activates. And it's about the size of a silver dollar. So it's a little bit bigger. It's kind of right there alongside the pacemaker in size for the newer pacemakers. Again, patients that have these, either the caregiver or they themselves will tell you about this, as long as they're alert. If they're having a current seizure, they're not going to tell you anything. Right. All our ostomies, so your colostomies, elostomies, and your urostomies. These are all procedures that create an opening in our intestines, whether it's small or large ones. So they may not pass stool at all from the rectum. Okay, and they may have a bag on the side of their belly. If these patients tell you that they have diarrhea or that they've been throwing up a lot, we do need to start thinking about dehydration. Again, waste products from our own body can be highly irritating to the skin. So if they've had a leak, if they've had a breach of that stuff, if the bag's not appropriately sized or placed right, they may have an infection start to develop. They may have redness along that site. Like it says right there. Okay? So those stomas are prone to infection. And we're looking for that if they're altered. Again, fever, signs of shock. It's one of the first things we need to look for, especially if you already know the history. Again, primary assessment, secondary assessment, getting hands-on and exposing the patient will tell us that kind of stuff. Urostomy, uro, we start thinking urine. And this is where we no longer use our whichever equipment we're hooked up with, whether it's male or female. Now we're just draining through a stoma in the abdominal wall. When we have these types of patients, again, ask how to treat them, ask how the facility or the caregivers take care of them. If all else fails, call medical control. Get some additional information. Here's my patient. Here's the signs and symptoms. They have a colostomy bag or they have a urostomy. Possibly looks infected. Do you have any orders or advice for me. Let them kind of help you treat that patient. Inpatient assessment wise, like we said, the caregiver is going to be our best bet. They're our best friend in this case. They know a lot more about it than we do. Use them, utilize them to the best of our ability. Let them be a part of the treatment process. They know about this patient far more than we ever will. That being said, make sure you know what their normal is before we even start looking at them. That way we can determine, okay, they are different from their normal, or this is continuing to progress worse. By doing that, we ask that important question down there. What is different today? Kind of along the lines of when we ask, what made you call 911 today? Why are we here? Not necessarily in those words, but you understand the meaning. All right, home care, we've got a bunch of different kind of populations for it. Anywhere from young to old, chronic illness, rehab, developmental disabilities. They utilize all kinds of different things. Some of them need meals cooked for them. Some of them get personal care. People come in, give them baths, make sure their clothes are cleaned, feed them. Physical therapy, they work with them. It just depends. That being said, a lot of times we get called out when these providers come and check on them. When we do, even if we're kind of grouchy that they called us out and it seems like the patient's okay, we need to get the baseline status, baseline medical history, what this patient's normal is from that provider. Again, they're used to seeing them. We are not. Hospice and terminally ill folks. Just be aware, most of them do have a DNR. Kind of talked about it before. Those patients, for one, we need to have it in hand. Again, a DNR order is no good to us if we don't have it present. Always ask with these patients, do you have advanced directives? What are we allowed to do? Some of them may not want IVs at all. Some of them may not want to have any kind of ventilatory assistance. It all depends on what those papers say. Most of the time with these folks, we're just kind of trying to make them feel better. They know they're dying. They know there's not going to be anything to help them out. That doesn't mean we need to let them suffer, right? So if we can, when we're transporting, if we can give any kind of pain relief or make them more comfortable within the scope of what their paperwork dictates, that's what we do. And most of the time when we see these folks, again, it's cancer, heart failure, lung failure. Alzheimer's is another one. These folks are in hospice, end-stage AIDS. There's all kinds of different diseases and issues where somebody can be placed on hospice. Like we just said, between protocols, what the patient wants, and what their paperwork says, we can work out some kind of treatment plan for them. Again, they know they're dying. We know they're dying. Doesn't mean we need to not care. Okay, everybody has the right to die at their home if they want, but they have the right to die with dignity. Sorry. Let's help them with that. Okay, make sure they're comfortable. Ask the family, where are we taking them? Do you want them to go to the hospital? Are they able to go to the hospital? Sometimes hospice paperwork is a little difficult to navigate. Okay, it used to be that if they went to the hospital, even just once for whatever condition they're put on a hospice for, it would revoke all hospice and they'd have to start the process all over again. It's gotten a little bit better, but again, ask the family, what are y'all's wishes? What do we need to do? Because the patient may, again, if they have Alzheimer's, they may be kind of dorked out and not necessarily know that they're dying. So Family may say no. I know they said they want to go. We talked to the nurse. We talked to his doctor. He's okay. We're going to keep him here. When we do that kind of stuff, we need to always make sure that the person taking care of them is the one we get refusals and authorization from. Poverty, homelessness, unable to provide for your basic needs. You don't have a house, you don't have food, clothes on your back, heating, air, basic necessities of life. With this, they don't have any disease prevention strategies because, again, they don't have anything. Homelessness breeds disease. Again, because they're out in the elements, they're exposed to that stuff. Like it says, the population includes people with mental illness, brain trauma, domestic violence victims, addicts, impoverished families. So, quite a few different walks of life to it. Again, same thing with everybody else. We treat them with respect and try to take care of them. Right? Everybody has the right to be taken care of. It's not our job to judge, it's our job to treat. Like it says, advocate for all patients. Okay, just because you're homeless, just because you are a drug addict, does not mean I am not going to take care of you. I'm going to do it the same way that I would take care of a Fortune 500 CEO. You know, our job, again, is to take care of patients. That being said, all healthcare facilities do have to provide assessment and treatment, whether or not a patient can pay. They usually give you that information right at the front door. If you can, get used to knowing what the numbers are for social services. Know what your community has available for these people. Do they have a battered women's shelter? Do they have a shelter for the homeless? Do they have programs for the addicted? Because remember, we're not just trying to treat this patient in this instance. We do want to make their life better. We do want to try and help them for the duration of their lifespan. If that means we can get them on track and get them into a halfway house or something like that, fantastic. All right, a little bit of review. Which of the following is a developmental disorder characterized by impairment of social interaction?
E.
B.
Yeah, all autism. Again, these kids, people don't necessarily interact very well socially. They may not like big crowds. They may not like more than two people. Known risk factors for Down syndrome include what? This one wasn't quite gone over, but we'll see if you guys can catch it.
C.
E.
B.
B.
So
Wait. Is it D?
C.
So it's C. That's my bad. We didn't quite go over it.
Oh man.
A lot of times, the older a female gets, the higher risk of having Down syndrome. Their children have Down syndrome. Again, it's a chromosomal defect, so it's something at the genetic level. Brain injury will be for your cerebral palsy patients. That being said, cerebral palsy can be caused by birth. You know, it can be caused by they may have suffered a brain injury during birth, but increased maternal age. Usually, it's after 40. So once you kind of hit 40, that's when they tell you you have an increased, a higher chance of having a child with Down syndrome. So if you haven't had babies yet, if you're fixing to hit 40, time is ticking. All right, which of the following may be difficult to perform on a patient with Down syndrome?
C.
D.
D.
Yeah, just about
A.
that real quick.
E.
Yeah, remember they got that got a small mouth. Their airway is a little bit more difficult. It's kind of like a child's airway. All right. Most patients with this disease also have hydrocephalus. That's water on the brain.
D.
C.
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 A couple different answers in there. It's going to be C. That's your spot.
C.
So these are the patients that will end up with those shunts to help drain that fluid. So what does the dope mnemonic help you recognize?
A.
C.
So when we're talking about dope, it was displacement, obstruction, pneumothorax, and equipment. So most of that when we're talking about these is for airway obstruction. That's when we're thinking intubation, tracheostomies. Helps us figure out if something has gone wrong, whether it's a piece of equipment that failed or something with their anatomy or the lungs themselves. What device is placed directly into the stomach to feed patients?
C.
D.
So remember, think back to your definitions and abbreviations. Which one is associated with stomach?
D tube. D.
Gastro.
C.
Remember, gastro is your stomach. So gastrostomy tube is going to be what feeds those patients. Most of the time, it's called a G tube when we pick anybody up. And again, those are the ones that run a high risk of being pulled out. So be aware of that. All right, what do vagal nerve stimulators do?
D.
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 Sir, we talked about that vagal nerve. When we vagal down, we might pass out because our heart rate goes down. Again, when we talked about this here, it's for the seizures, both to try and keep them from happening or as an alternative for medication for seizures. All right. Important part of the assessment process for a patient with special needs is to what?
A.
Yeah, hey, a couple of those were pretty good answers, though. But yeah, we definitely want to interact with the caregiver. Again, they're used to it every day. They're experts with it. They're trained. They're used to this stuff going wrong or how to operate it. We're not as proficient. That being said, we do want to talk to the patients. It's more important to talk to the caregiver because they're, again, the ones taking care of them. Talking to manufactured equipment, that's not necessarily going to happen. And then transporting immediately, not necessarily. All right, so what improves a patient's quality of life shortly before death?
B.
I guarantee
C.
oh,
D.
man.
D.
So most of us would have got this wrong because I would have answered the same way. So despite hospital, it's actually comfort care. which is part of hospice care. Kind of a mystery.
Okay, makes sense.
But
True.
just be prepared. That's kind of what National Emergency does to you, is it give you questions like that. So I like that. That's good. And with hospice, it doesn't always necessarily mean that they're dying. They may be on hospice while undergoing chemo treatment or anything like that. But comfort care, palliative care, as it's called, is what it's talking about. All right. So we didn't call it by name, but the EMTALA Act states what?
A.
B.
B.
Yeah. So that's the Emergency Medical Treatment and Active Labor Act. So if you have the right to be assessed and treated, regardless of whether or not you can pay. All right. Let me pause this. So, all right. So transport operations. A lot of this is going to focus on the ambulance and, again, how we transport patients. We know they're stocked with just medical supplies. A lot of our stuff, like our monitors, can transmit information to the hospital through Bluetooth, through wireless capability. That being said, that rapid response does put us in danger. If anybody has been on a truck with us, sometimes we drive too fast, sometimes we blow through red lights, and we shouldn't. Again, it's dangerous out there. We have to be extremely careful. By definition, an ambulance is a vehicle that's used for treating and transporting patients who need emergency medical care. Today's ambulance designs are based on NFPA 1917, the standards for automotive ambulances. With that, it's just done with suggestions from the ambulance industry itself and from EMS personnel all over the country and the world. Because we know that the ambulances of today are certainly not the ones from, 30 years ago. So, like you guys know, first responder vehicles have personnel and equipment to treat patients until an ambulance shows up. You guys are very good at it. It's very greatly appreciated. If it's not said often enough, it should be. So a couple of different components of the modern ambulance is we obviously have the driver compartment. That's where we sit. That's where we drive. It's got our navigation, our lights and sirens, how everything works. And then we have the patient compartment, which is big enough for 2 EMTs and 2 supine patients. Doesn't seem that way sometimes, but we can put at least 2 people on their back in there. Depending on your service, equipment and supplies varies. Some carry ALS equipment like IV bags, medications, innovation equipment. BLS services probably do not. They'll carry the basic life support stuff, your VBMs, your bandaging and splinting. So it just depends on what that service is. Two-way radio communication, we talked about that a long time ago. Ways to communicate with both the hospital, our dispatch system, and other units. This bottom part is supposedly designed for maximum safety and comfort. That's probably a personal opinion. But they are designed to be safe for the patient for sure. Okay, we obviously, when we put them on the stretcher, they need to be safe transportation wise. Each state has their own certifications, licensing standards for ambulances. That being said, the Star of Life is symbolic, and it's placed on whether it's the rear, the side, the roof. It's all over these ambulances to identify it as such. That way other people know that this is an ambulance. This is driving down the road, lights and sirens to take care of somebody. Different phases of an ambulance call. For one, preparing for it. That starts at the beginning of your shift. Having everything ready to go. Making sure everything's stocked up. Having enough oxygen. Then you start from dispatch, getting the call itself, checking en route, arrive at scene, transfer the patient to the ambulance, start transporting them to the hospital, get them to the hospital, go back to the station or post, complete your paperwork, decompress. Just like you guys do, pretty cut and dry. Again, preparation phase, we need to make sure when we start in the morning that everything looks good. Everything is ready to go. Equipment works. It's in date. It's in stock. We have enough of it. Nothing's broken. Most of the time, especially if you've seen any of our boxes, you know everything is placed in a specific compartment or a specific way according to how often we use that stuff. Pretty much every ambulance is the same cabinet wise. They're all transparent so that we can see inside it, or they're labeled as such. We need to be able to open and close them easy so that we can get into them, right? Nothing's worse than trying to use a key to unlock something while somebody's dying. Again, medical equipment, basic supplies, airway and ventilation equipment, CPR equipment, patient wound care. So with us, that blue airway bag has pretty much everything we need in it to take care of a single patient. And there's some more additional equipment. Most of this you can find as the standard minimum equipment list for an ambulance, according to the state. And some more equipment, patient transfer equipment, that's a Titan tarps, stair chair, stretcher, medications, and then the jump bag. So quite a few different things, different pieces of equipment. Try to be familiar with all of it if you can. Again, when you're going on clinicals, ask, hey, can you show me where this is? Hey, can you show me where I would go to help with this kind of patient? Ask them to open this stuff up. Get familiar with each different box. Depending on if you're coming out of Tyler versus coming out of a county unit, they may have things set up slightly different. Safety and operation equipment, personal safety equipment. That's your high visibility vests, your goggles, safety glasses. Right now, your N95 mask, respirators, all that. Equipment for work areas, replaning navigation equipment, and extrication equipment. All of these are, again, in that preparation phase before we even get started for the day. We want to make sure all this stuff works, that it's available. Personnel wise, at least one EMT has to be in the patient compartment during transport. Well, yeah, we don't throw them back there and just look through the compartment door and say, you all right back there? No, we take care of people. So one of us has to be in the back at all times. Daily inspections, something that a lot of crews probably do not do, that needs to be done. You need to inspect the ambulance. Check the oil, make sure there's enough fuel in it, make sure it's clean. Again, we're professionals. We need to act like it, right? We want to make sure that we look the part. So review your safety precautions. Again, make sure everything works. Case in point, had a student and the high visibility vest was stuck underneath the captain's chair. So one of us went without the high visibility vest. Always make sure that your equipment works or that it's available and not stuck or broken. Make sure your oxygen tanks are secure. Again, those are highly pressurized things. If something gets knocked loose, it could become a projectile. And make sure all your stuff's sealed or at least closed, because nothing sucks worse than trying to take a patient to the hospital, having them take a hard left, and that cabinet that you forgot to close now has hit you in the face with everything in it. All right. Dispatch must be easy to access and in service 24 hours a day. That's our dispatching systems. Okay, just like Smith County Dispatch, EMS Dispatch, all those need to be available. And they all get quite a bit of information when they can. You know, what's the reason for the call, their name, where they're located, and the callback number, and the location of the patient. Those three right there are always gotten first. That way they can start whatever service, whatever unit needs to go in that direction. Everything else can come secondary. Other pertinent information would be, you know, how long has this gone on? Have they taken any medications? Anything related to the initial chief complaint that they were calling about. So the en route to the scene. Obviously, this is the most dangerous part for us because, again, we're driving with lights and sirens. We're trying to get to these calls. And unfortunately, people don't know how to drive sometimes. Crashes do cause serious injuries. We need to make sure that we have our seatbelts on. Unfortunately, some of our own employees don't know how to wear seatbelts. Encourage everybody to wear them. Okay, they're there to protect us. Review your information, see if there's any updates dispatch-wise. And this is the time where you start working with your partner to get a game plan of, okay, this is what we know we're called out for. When we get there, we're going to do this, 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 and this. If we see this, this, and this. If we see this, we'll do this. If we see that, we'll do this. Helps you kind of get your game plan going before you even put feet on the ground. Arrival at scene. We've done this. Scene size up. We're looking for safety hazards. We figure out if we need any more units. Find out what caused the problem. Check C-spine. Standard precautions, BSI. Okay, we've kind of gone over that before with our scene size up, primary assessment, and all of that. When we encounter mass casualty incidents, which is more patients than we have resources for at the time, we need to try and get how many patients there are and give that to whoever is in incident command. That way we can start working on getting more resources. And when we park, it says allow for efficient traffic flow and control around an emergency scene. Park 100 feet before or past the crash, and do not park alongside a crash scene. Book-wise, absolutely correct. Same time, I personally try to protect the scene if I can. If I'm first, I will protect that wreck scene with the ambulance because I do not want to get hit. At the same time, plan accordingly. It's easier to drive forward than it is backwards, so don't kind of pigeonhole yourself into having to drive out backwards 1.5 miles. Here's a little figure to show you where we need to park ambulance-wise. Again, it shows that the fire department has gotten there first. They're protecting the scene, kind of like what I had originally said. If we are secondary, when we are talking about EMS, we do need to park a little bit away from it. That way we're not in the way. We have an easier way to get out. If we know there's any smoke or kind of hazardous materials, gas, always park uphill, upwind. We don't want that stuff flowing down to us. Keep your lights on so people can see that you are parked and you're not moving. If we can, ideally we want to try and get out of there fairly quick. That being said, we want to make sure we're staying away from anything potentially hazardous. Fires, exposed down wires, unstable building, unstable vehicle. Just use your head. You need to make sure that you are safe. Again, when we talk about scene safety, our number one priority is always ourselves, our partner, first responders, bystanders, and then the patient. So again, if it's necessary to block that traffic, we do need to work safely, but we need to try to work quickly and get out of there if we can. If we do need to provide traffic control, do so. Again, our initial primary job is patient care. Place warning devices on both sides of the crash. If we have, each ambulance should have some safety triangles in them. So we do have some devices available to keep us safe. It's transfer phase. Obviously, we've gotten the patient. We figured out they need to go to the hospital. They need to be packaged, whether that's securing them to a backboard, scoop stretcher, wheeling them in onto the stretcher. We need to get them in there. 2-man lift, always for us. Lets them into the compartment. Lock it in. They are always going to be secured with the straps. Don't ever transport somebody without having them buckled in. When we are transporting, most of the time we don't need to go real fast. Okay, even if it's a cardiac arrest, even if it's something super bad, like they've got both their arms cut off and they're bleeding out, going extremely fast doesn't always help. Yes, we need to get there in a timely fashion, but rushing like that and having a wreck and now we're all 3 injured doesn't do anybody any good. So drive defensively, be safe. Because I will tell you that, especially on cardiac arrest, I don't have them turn the lights and sirens on. If we're working it, we're just going to take it nice and easy. You're ready to leave with the patient, inform dispatch how many patients you have, where you're transporting to. We don't necessarily have to do this anymore, but beginning mileage of ambulance, that's more of a billing thing, or depending on your contracts, it may be a stipulation. So just be aware of whatever service you're at. If they require you to state the mileage, do so. Most of the time, at least with us, in our case, you're going to be telling them, we're going to be transporting priority 1, priority 3 to Mother Francis or to UT Health with 1 patient. Again, something going back to our reassessments, talk about stable patients every 15 minutes we'll reassess, unstable every 5 minutes or less. Make sure to contact the hospital, let them know we're coming, what we're coming with, vital signs, what we've done for them. This is something that probably needs to be worked on quite a bit. Don't abandon their emotional state. There's a lot of us that sit back over on in the captain's chair. We don't talk to the patient anymore. I can tell you that there's some times that I've done that, especially if there's not a whole lot to do with this patient. Again, we're transporting them in an ambulance. It's not the most pleasant of situations for them. Try to talk to them. Delivery phase is where we are now taking them into the hospital. Okay, we're going to let the dispatch know, hey, we're here. Once we walk in, we're going to talk to the patient or to the triage nurse or whoever is available and say, hey, this is the 26-year-old diabetic patient that we just called about. They'll hopefully give you a room. You'll transfer the patient over to the bed, give a verbal report to the hospital. Eventually, you will complete a detailed patient care report, document it on the computer, and then afterwards, you will reorganize and restock your ambulance if available. Most of the time, it's just putting everything back together to run another call. If you were lucky enough to get to go back to the station, you'll tell the dispatch, we're clear. Once we get back, this is assuming we don't do this already, cleaning, disinfecting the ambulance and equipment, and restock. Cleaning and disinfecting the equipment will probably come right after we drop the patient off in the bay. We do have cleaning supplies on the ambulances. We can clean that stuff. Afterwards, when all is said and done, you're going to finish your reports, make sure they're sent off. Legally, we have 24 hours to complete those reports from the time of the call. Again, once we get to our station, we let the dispatch know, hey, we've arrived at 304 or we're out at White House. That way they know which location we're at. Refuel, make sure everything's good to go. And get ready to do it again. So there's a couple different key terms. Cleaning, we're just kind of getting the dirt, dust, blood, any kind of contaminants off the surface. Disinfection, we're actively trying to kill those pathogenic agents by using chemicals that are made for that. High level disinfection is a step higher. We're using more potent disinfection materials, and then sterilization is using like heat to remove any kind of microbial contamination. So a couple different steps. Most of what we do originally is cleaning and disinfection. Now we've moved into, with coronavirus, that high level disinfection. When Ebola was kind of around there for a hot minute, sterilization was something that was being used quite a bit down there in Galveston and UTMB. So after each call, we're going to take the linens off the stretcher, discard medical waste, wash anything with soap and water, or wipe it down with your sandy wipes, disinfect the stuff we can't throw away, and clean the stretcher and look for any other kind of contaminants and clean it up. Just kind of clean it up after yourself. It's always good to have a good schedule for it. Up here in Tyler, our make ready crew and VSTs do a good job of taking care of our trucks for us. Outlining stations, it's entirely on the crews. Every shift they should be able to take care of their trucks and make sure it's ready to go for the next one. Whether that's having a cleaning schedule themselves or what they've written up, just make sure that you're taking care of it. All right, defensive driving, ambulance involvement, crash, again, delays patient care. It also may end up taking our lives or anybody else around us. In some states, they do have to have completion of a emergency vehicle operation course, EVOC or CEVO. We do that up here. You need to be physically fit and alert for this. Emotional maturity, stability, and due regard for the safety of others. All of that should be a good driver, period. Somebody that's aware of their surroundings, they know how to drive appropriately, they keep an eye out for other individuals and hazards. Physical fitness and alertness, when we kind of get in depth to it, it doesn't mean like you need to be big, buff, and tough. It's more of how capable are you of operating something. Have you been taking any medications that may cause drowsiness, slow your reaction time? Have you been drinking alcohol? Have you worked, a 48-hour shift and had no sleep? Things like that are what affect your fitness and alertness to operate a vehicle. Safe driving practices. Like I said, speed doesn't save lives. Okay, good care does. That doesn't mean don't, drive like a grandma everywhere, but don't rush. Yes, we want to get to these places in a timely fashion, but we want to arrive alive. Same when we get to the hospital. So just drive appropriately. Wear your seatbelts. Make sure you know how the ambulance works. Some of these ones will stop on a dime. Other ones, you can put your foot down in the dirt and it's going to go another, 40, 50 feet. Make sure you know how that certain one that you are using operates. Stay in the left-hand lane if you're running emergency lights and sirens. Most people, I say most, are still taught that when they see emergency lights and sirens, they move over to the right. So as long as we're in the left lane running lights and sirens, we should be unhindered. We all know that's not necessarily the case. Siren risk benefit. Depends on your protocols, the condition of the patient, and the outcome. When I was talking about patient condition, if we turn the lights and sirens on, is this going to make them worse? Are they going to start panicking because now the lights and sirens are on? That only means people are dying. I wasn't dying a second ago. Now you're saying I'm dying. It may agitate them more. At the same time, if we think they're going down the toilet, and lights and sirens may help people kind of move out of our way and expedite the process of getting them to the hospital, might be indicated to use them. Gyro anticipation, all it means is assume that everybody else does not hear you. We all know how loud we listen to music sometimes. I crank mine up when I leave. I may not hear the sirens until it's right up on me. So always assume that they cannot see you, that they cannot hear you. Drive defensively. The best way I can say it is drive like everybody else is an idiot, and you will be safe every single time. Cushion of safety, give yourself some space, okay? Don't tailgate. It's hard to avoid being tailgated from behind, especially when we have family members that follow us. Again, when we're leaving somewhere, try to explain, you can follow us, but please maintain a safe distance in case I need to stop immediately. Try to know what blind spots there are and how to accommodate for them or move to eliminate them while you're looking. That way you don't hit anything. Don't get out of the ambulance to confront somebody. I don't care if they pulls you off or cut you off or brake checked you. Let it go. That's not our job. You can get on the radio and let somebody know. But don't agitate somebody else and cause a problem, especially if you already have a patient on board. Just like in your regular vehicle, make sure you know your blind spots. Check your mirrors all the time. We are in a ginormous vehicle that does not drive the best all the time, with somebody standing up in the back possibly, doing patient care with possibly sharp objects or heavy equipment. We don't need to be herking and jerking around. So we need to make sure if we're going to change lanes that we are looking at our mirrors, making sure, yes, we have space to do that. That way there's not a vehicle there that all of a sudden appeared and now we have to jerk back over. Again, like I said, speeding doesn't always help us out. Okay. The faster you go, the crappier your reaction time is. Okay, so if we can avoid it, we need to not speed. Okay, I know sometimes we like to get into these vehicles and put pedal to the metal, but it doesn't always end up benefiting the patient, especially if we end up wrecking. There is such a thing as siren syndrome. Okay, people do start driving faster if they see us or hear us because they freak out like, oh man, I gotta get out of the way. So what do? They floor it. Same thing when they're at stoplights. They may progress into the intersection to get out of your way, further potentiating danger. Remember, we're a bigger vehicle, just like the engines. Distance judgment, vehicle size is important. If we're going to back up, use a spotter. Make sure somebody's looking out there or out there in the first place to see you. That size, that weight makes it harder to stop. We need to be aware of that. So if you're fixing to have to stop somewhere, if the light changes ahead of you, 100 feet, 200 feet, probably a good time to start slowing down. That way you're not slamming on your brakes and end up, half a car length into the intersection. There's a little bit of a picture for you for road position and cornering. Again, enter high. That way you exit low. Stay in your lane. It should not be too terribly hard to operate this thing. Weather and road conditions. Again, just like your normal vehicle, you don't operate the same when it's inclement weather out, when it's raining, when it's snowing, and you can't see very well. Same thing with an ambulance. Drive slower, drive more careful. All right. So, laws and regulations wise, if we're using lights and sirens, if we're on an emergency call, a couple of different things we can do. We can do some of those items that are normally illegal. We can park in an illegal place. We can go through a red light or stop sign. We don't need to. We need to check it first and stop and then proceed slowly. We can drive faster than the posted speed limit by a certain amount. We can drive against traffic. We can drive into oncoming traffic. We are legally able to. I would highly suggest you don't do it. It's a little scary. You travel left to center and make an illegal pass. Okay, so all these things we are able to do because we are exempt. That doesn't mean we do them all the time. We are not allowed to pass a school bus if they're stopped. If we ever see that, you have to turn your lights and sirens off and come to a complete stop. Does not matter what we are doing. When we do use lights and sirens, obviously we have to be on an emergency call. For us, that's priority 1 or priority 2. They have to be used at the same time, and we have to operate with due regard to others. So even though we have these lights and sirens and are trying to tell people to get out of our way, we still have to operate that vehicle defensively and safely, okay? Because we're still responsible for it. Right-of-way privileges. We get to kind of throw those rules to the wayside for the most part when we're responding to emergency. Okay, that doesn't mean we endanger people. So make sure you know kind of the local right-of-way privileges, what we can get away with, what we can't get away with. Escorts aren't too bad if you don't know where you're going, but ideally we need to try not to use them. For one, if they get too far ahead of us, it could cause a problem. They also may go faster than we are, and again, it creates another vehicle that could potentially cause a danger. Intersections, we all know, are extremely dangerous. If you can't wait for the traffic light to change, to go ahead and go to a brief stop and look for hazards. For us, anytime we have a red light, we always stop first and then clear each lane going 10 miles an hour or less. If you're not seeing that happen, please let us know. Okay, we're trying to keep everybody safe. Highways, ideally, like I said, we need to shut the lights and sirens down until we get to that left lane. You guys know as well as I do, most of the time when we get there, people drive faster than us anyway. But again, lights and sirens means pull over to the right. We don't want to cause an unnecessary accident. Unpaved roads, slow down. We're not going to try and go as fast as we can. We need to make sure that we are controlling our vehicle. And then in an active school zone, you go the speed limit it states. If it says 35 miles an hour, I don't care if you were going 75 beforehand. Slow down, go 35. Distracted driving, it's out there. We probably all do it at the same time. We need to make sure we minimize that when we're on the ambulance. Whether that's looking at dispatch information, trying to mess with our phone, mess with the radio, or if we're trying to scarf down something to eat on our 10th hour of a long shift. Okay, if you are driving, you need to focus on exactly that, just the driving. Because it's your responsibility. And if you're driving alone, you have to figure out what the best route is while preparing for the call. Again, all of this stuff demands your attention, demands your focus. You need to be hyper aware and head on a swivel making sure you're safe and the vehicle is safe and everybody else. So again, drive defensively. If you do start to get tired, let your partner know, let your supervisor know. In a perfect world, you should be placed out of service. Okay, you should not be allowed to operate the ambulance or anything until you are feeling rested. We all know that's kind of a pipe dream. Air med, fixed wing, rotary wing helicopters, they are available. Fixed wings are used most of the time for inter-hospital or inter-facility transports for more than 100 to 150 miles transport. Helicopters are better for shorter distances. You guys know it as well as I do on calling for helicopters. With Air Mid, most of the time they're a little bit more highly trained than we are. Okay, we provide the ground support. They do more in-depth skills, more invasive procedures. Their protocols will be different than a ground crew's. It just depends on their medical direction. A couple reasons to call for helicopter. For one, if transport time is going to be way too long. If we're being blocked off and we cannot get this patient out, if they need way more care than we can handle, or if we have an MCI event. Most time, if you think it will benefit the patient, it's probably a good idea to call. If it's going to be a long extrication, possibly a good idea to go ahead and call for air. That way, once we're able to get them out, they can transfer them onto there and take them very quickly to the hospital. So who receives it? Well, just about anybody. Depends on what they have. Any kind of significant injury or illness can warrant a helicopter ride. And with that, it depends on what facility they're going to go to. Case in point with our area, if there is a burn patient, usually a good idea to call for a helicopter because we don't have a burn center close by. Closest one's LSU in Dallas or Parkland. Neither of which are very quickly accessed by ground, but by helicopter it's infinitely quicker. Most time you'll let the dispatcher know, hey, we need to get a helicopter, and they'll facilitate that. Establish the landing zone. Good thing is, thankfully for me and EMS, you guys are incredibly good at handling this. You guys know how to set up an awesome landing zone. Ideally, hard grassy surface area, 100 by 100. Don't want any loose debris, no overhead hazards. Needs to be visible. Don't use flares again because a lot of times they have specialized equipment to see in the dark so that they can see where they're going. Those flares may cause issues. Ideally, we need to get everybody out of the area and let them know if there's any issues, strong winds, power lines, anything that can cause a problem. Once they land, we need to make sure we're keeping a safe distance. Obviously, stay away from the tail rotor if it's open. Otherwise, you won't have to worry about anything afterwards. And always approach from the front. Most time, the air crew will be the ones directing you to do this. They're used to it. They know how to do it. Follow their lead. Here's a kind of picture of what you need to be careful of. Ideally, stay away from that back end unless you want to be some chopped beef. So keep these guidelines in mind. Hand signals if you need them. Again, you're not going near the helicopter unless you're told to, or you're taken there. Make sure all the equipment's secured. That way it doesn't get sucked up, thrown around, blown off. and wear eye protection because it can kick debris up into your eyes. There's a couple air traffic controller signals for you. If you need to do that with them, most of the time they're pretty good at landing on their own. Night landings, we're not going to shine spotlights. We don't want to distract the pilot. If we can, we do want to make sure we eliminate those hazards if there are any. And that way we keep them safe too. If they do land on uneven ground, we need to be extremely careful. That blade is going to be closer to the uphill side, so we don't want to go in that direction. Always approach from downhill. There's more space. We won't get our heads chopped off. If we do have some kind of gas, smoke, chemicals, we do need to let the flight crew know. That way we can adjust the landing zone accordingly if we need to. That way we're not blowing this chemical or gas around and causing a further problem. Ideally, decontaminating the patient is a must before we load them in. Most of the time the helicopter is even smaller than the ambulance is. So if we don't clean them up, they'll have a higher concentrated gas in there and exposure. Evac issues, again, assessing the terrain, the weather. If there's clouds out that are pretty heavy with rain, if there's thunderstorm, they may not fly. Most of them are limited to how high they can go and how fast. Always tell them how big your patients are. Depending on the helicopter, they may not be able to take a very heavy patient. They may also not be able to take more than one additional person. All right. So all the following are examples of standard patient transfer equipment, except what?
A.
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 Yeah. So all the other ones we talked about, a stoops basket is kind of a more specialized piece of equipment. Definitely not something we use all the time. All right. Primary purpose of a jump kit. It's also called a
Start your truck.
5-minute bag.
D.
D. D.
D.
Yeah. So their jump kit, their definition is going to be that D, that 5-minute kit. It's what you're going to need in the first 5 minutes. Like I said, with our bags, we're going to have access to everything we're going to use. Majority of the time, it's for ineffective ventilation. But ideally, it's what you need in the first 5 minutes. There's a BVM, there's oxygen, ventilator. You know, if you look at any kind of jump bags, most of it is very basic level stuff. All right. You can dispatch to call for an unresponsive patient. The most important information that you should obtain.
C.
D. C. Yeah, no, here's that.
Think about those
C.
3 things that we talked about that we need to get first. That dispatch has to get first. It's going to be D. We have to know where the patient is to get to them, right? So we do need to know that they're breathing, but we need to know where they're at first.
Another trick question.
Kinda. All right, so we're en route to a call for a major motor vehicle collision. The most important safety precaution that you and your partner can take is what?
D.
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 Yeah, we want to wear our seatbelts. Okay. All right, which of the following is not a guideline for safe ambulance driving?
C.
D.
C.
Yeah,
C.
we want to try to avoid one-way streets. For one, we're going to get clogged up. Right? We can't. If we get them blocked up, then we can't go that way in the first place. All right, at what speed will the ambulance begin to hydroplane when there's water present on the roadway? I'll go ahead and give you guys this one. We didn't talk about it necessarily. It's going to be 30 miles an hour. And that speed's
So it
pretty
would
much.
depend on how good the tires are.
Most vehicles, if there's enough water, they're about 30 miles an hour. You can start to hydroplane. But yeah, so that's going to be 30 miles. There is not a test question about that. I'll make sure. All right. Most common and often serious ambulance crashes occur where?
D.
D.
B.
D.
D.
B.
Yeah, them intersections. Intersections are rough. Okay? A lot of times people don't pay attention to us. So if we're not paying attention, we run a very high risk of being hit. Recommended dimensions for a helicopter landing zone. What is they?
D.
C.
D.
D.
Yeah,
D.
100 by 100. We'll make sure it's clear of all kinds of debris, any loose lines, anything that can cause that helicopter to crash. All right, which of the following statements about helicopters is true?
A.
A.
E.
A.
Yeah, so it's gonna be those rotors have a tendency to dip down. If it's on a grade, we want to go down on the downhill side so we have a little bit more room. Personally, I am not going to move from one side to the other. I'm not going to roll underneath the ambulance or the helicopter. I'm not going to go around the front of it. I'm going to just not go around. All right. Upon arrival to the scene where hazardous materials are involved, you should park the ambulance where?
A.
A. A.
A.
Yeah, we want to be upwind, right? We don't want that stuff to contaminate us or get near us. All right. So let's exit this one. So we're going to talk about incident management. These can be extremely overwhelming. I'm sure you guys have known it. You guys have probably seen it before. Like I said, most of the time, 3 or more patients or whatever overtaxes our resources. If there are more patients than what we can handle, it is an MCI. Incident command systems make it so we can help the most people. National Incident Management System, NIMS, puts on a buttload of courses that really help out. You've got your ICS 100 through 800, all good courses to take. Definitely something to look into because it helps us coordinate not only just with our local people, but if we're doing an entire region, the state, the nation, kind of keeps it unified. It was created in 2004, gives a good framework for incident management. Again, it helps everybody from like private sector to government agencies to non-government agencies to work as a team. That being said, it teaches that your structure for the organization has to be flexible enough to change at a moment's notice. It keeps everything standard. Standard terminology, resources, personnel training, certifications. That way there's not 15 different subcategories based on fire service, based on EMS service, based on law enforcement. It keeps everything unified so that if you say, hey, I'm certified with ICS 200, 300, 400, somebody from a law enforcement agency in California says, okay, I know exactly what you're talking about. That way it keeps that kind of interoperability so that different agencies can communicate with each other. Major components of it: preparedness, communication, information management, resource management, command management, ongoing management, and maintenance. All the things we need when we're doing these major casualty events where we're overloaded, we're stressed out. These things help prepare us for that. Incident command. For one, this keeps us safe as the responders and the public. That way they're kind of out of our way and we're making sure we're all accounted for. Helps kind of achieve those goals of incident management where we have one person controlling the situation. They know what's going on with this, how many patients there are, who's taking what, which services are here. And that keeps all the resources being used the right way, in the best way. So what it does, like I said, is controls duplication of effort and freelancing. Keeps people from just coming in and saying, well, I'm just going to go ahead and take this patient while we're waiting here because y'all haven't figured it out yet. Or keeps two services from doing the exact same thing when there's something else that can be done. Keeps our control of the situation kind of high and tight. That way there's not too many chiefs and too little Indians, for lack of a better term. And it breaks it up. It breaks it up into sections, branches, divisions, subgroups, teams. That way there is organization to it for ease of communication. That way you're not just trying to say, okay, well, Unit 838 from UT Health or Medic 3 from Christus. You're saying, okay, Transport Division, and they'll figure it out from there. You'll have Transport Division, Transport 1, Transport 2, Transport 3. Again, that way it's all unified and keeps everything normal. So there's a little figure for it. For the organizational structure, you've got your operations, planning, logistics, and finance. And then it's broken down by branch and then division or the group. So your roles, again, there's quite a few of them. Some of them may be used all the time. Some of them may not. There may be one or two that aren't used depending on what the situation is. If we're out on a major wreck with 5 different units and 3 different fire departments, probably not necessarily going to use finance at that moment. They are a factor in reimbursement and things like that, but not necessarily at the scene. So command, again, incident commander is head honcho. They're in charge of the whole thing. Always important to know who it is, how to get hold of them, and where they're going to be at. They should be in a centralized location that's easily accessible, and they should be able to be gotten a hold of, whether that's via radio, phone, however they can get a hold of them. The good thing about incident command is it's transferable. So if you arrive first on scene, guess what? The most qualified or highest certification individual probably will be incident command. If you're, chief, regional director, director of operations, whoever comes in and has far more experience than you, you can transfer that command over to them and then move into whatever branch that's needed. Finance, again, that's kind of talking about the money for it, expenditures, keeping a clear list of it. That way we can get reimbursed. Logistics is kind of the materials portion of it. Are we using a bunch of food and water? Do we need a bunch of Gatorade? Are all our trucks fueled? Do we need to bring in additional units? Do we have good lighting? Are we supplied? Again, these are all talking about large scale incidents where we may have to have things brought in, bombings, the tornadoes down in Canton, things like that. Things that could cause a high amount of destruction in a lot of patients. Operations, again, that's managing the operations, okay, how things are working. They kind of maintain the scene. They keep an eye on the people who are actually working in the scene. Planning kind of takes a back seat. They're not up in the action. They're developing those incident action plans. They're figuring out what needs to be done, how we're going to do it, and anything that comes up, they're figuring out ways to take care of it. Operations wise, those section chiefs come up with who's going to be doing what. They're gonna decide which divisions they have. Division 1, Division 2, and then Group 3, Group 4, however it's going to be set up, and they communicate that to Incident Command. Command staff, security officer, obviously they're going to kind of keep an eye on everybody for safety. They're going to make sure everything's working correctly and keep things from being a hazard. Public information officer is usually your liaison with the media. That way they're not kind of running in there trying to get information from everybody on scene. They'll kind of keep them updated with what's going on, answer any questions as long as they're available or if they have the answers, and overall keep the media off our back so we can do our jobs. And then they relay that information back to the command staff and to everybody else. Like it says, I'll tell you that's really the truth, is communication is our worst part of this. We're not very good at it. Ideally, we need to make sure it is integrated. Most of our radios now have TAC channels. We need to utilize them more often because communicating gives us the chance for instant communication accountability, making sure that we are taking care of each other and taking care of these patients in this situation. All right, so when we actually get mobilized and deployed for this stuff, obviously when you first get there, you're going to ask, hey, who's incident commander? You're going to get with them and say, okay, where do you need me at? They'll say, okay, well, your supervisor's over here in this location. Go there. And you'll talk to them. They'll give you kind of an update, let you know what's going on and where you need to be. And most of the time, there will be some form of record keeping. That way we know how long somebody's been there, what they've done, what supplies were used. That way there's always that reimbursement. So accountability. We have to let our supervisors know where we are, what we're doing, and what we've been successful with. It helps keep us safe. That way they know where we are in case something goes wrong. It also lets them know what they need to report to Incident Command, whether we're being successful or whether something needs to change. once the major part of the problem is addressed, we start controlling the situation. Incident command can start deciding, okay, well, we don't need 14 ambulances, we only need 8, and they can start demobilizing those and sending them back. So EMS response specifically, we're talking about preparedness. All this involves decisions, planning for the most likely natural disasters. In our area, obviously, like we just talked about, tornadoes are a big problem. They've kind of kicked the tar out of us the last couple years, and we've had some of these incidences. Ideally, our agency should have those disaster plans written out that we can train with. Probably something we need to be a little bit more adamant about so that we can continue to improve our responses to these. That disaster plan should be kept in every vehicle. That way we all have an idea of what we're supposed to do. So when we talk about incident command, MCIs, scene size up, we're going to kind of make that initial windshield survey and kind of make a few decisions. First off, what do I have? Well, we have an ambulance, we have 2 crew members. What do I need? However much we think we're going to need, however many patients we can see that are going to need to be treated, and what do I need to do for that? So most of that will involve finding out truly how many patients we have and asking for the resources we need. Again, command is going to be established pretty much the minute we step on scene for one of these, and the most senior official. Usually that's going to be the most credentialed member of the team. So in our case, it'll be whatever paramedic is on the truck. At that point, they're going to get on the radio and say, hey, we've got an MCI level event. I'm going to need this many resources. I'm switching over to TAC channel 1. That way they can get the process started. Once we are actually on scene with all these folks, it'd be nice to do face-to-face communications. We all know that sometimes that's not going to happen. Radio is going to be some of our best options. Not going to use signals, not going to use 10 codes. We need to speak clearly and as detailed or briefly detailed as we can. We don't want to take up a lot of time, but we need to get our information out. Again, all that equipment, like we talked about in the last lecture, it needs to be reliable. We need to make sure it was checked and tested and works. And make sure that there's a backup plan and backups in place in case something fails, especially communications-wise. If your radio goes out, what are you going to do? Well, we're supposed to have the phone number to dispatch. We can call dispatch and relay information that way. So when we talk about incident command, EMS is the medical portion of it. Most of our role is, again, triage, treatment, transport of injured people. Okay, we work on the patient care side of things. So there's the EMS branch. So that branch, of course, it starts with the medical command, and then you have your triage, treatment, and transportation, and the different tasks associated with it. So triage-wise, your goal is always to find out how many patients we have and get them appropriately assessed. Whether that's, with tags, written word, stickers on their chest, whatever tags you have available. Treatment-wise, we'll set up a treatment area and start treatment accordingly. We'll kind of arrange them critical, non-critical, and then what would be the green or walking wounded. And then transportation-wise, you'll have a designated area where they can come in, pick up a patient, and take off. Triage supervisor, again, they're in charge of finding out how many patients we have and how severe each of them is. They have the hardest job. They have to run in, They have to check everybody and be able to say, okay, well, this person's obviously dead, or this person is critical. Sometimes it's incredibly hard to do because we don't do any treatment during this stage. Treatment supervisor, again, you're going to set up the treatment area and you're going to work on setting up treatment options. Okay. Once they get triaged and once they get transported over to you, you're going to do a secondary triage and make sure that we're doing everything appropriately. They'll also help facilitate moving these people into the next stage, which is that transportation portion. And that supervisor makes sure that they coordinate with the crews coming in where they're going to pick up, where they're taking the patient. Because they're going to document all that. They'll make sure that they know how many people were there, how many have been transported already, and where they've gone. So your staging supervisor, this is going to be when we have multiple different people there, fire departments, other EMS services, law enforcement. This way we can kind of keep everybody close to the scene, but nobody's piled up on top of each other. And we have a smooth mode of transportation. We have a one-way in, one-way out. You know, your fire department goes this way, your law enforcement, you're coming up here, and then EMS, you're going this direction and out that way with transport. So lots of moving parts. If you have physicians on scene, great. They can provide, you know, on-scene medical direction. Most of the time they'll be in the treatment area and they can help make triage decisions. They can sit there with their experience, with their knowledge, and say, yeah, this person is a red tag, or no, go ahead and put a black tag on them. They're not gonna make it out of here in time. Honestly, it's fairly rare for a physician to be on scene. Rehab supervisor. These are going to be kind of along the same lines as safety. They're going to make sure that our people are taken care of, that they're hydrated, they're rested, they're staying dry or staying cool, whatever they need. Because, again, a lot of these incidences can take a long time and they're extremely stressful. We may be out there for 13, 14, 15 hours for a single shift. And the entire incident could take 3 or 4 days, you know, depending on what it is. These guys are looking out for us. Special Rescue determines the type of equipment, and then they also, again, function under EMS. Sometimes they're under the fire department. It just depends on how the incident command was set up. If we have a morgue supervisor, they set up where we take the black tags. Ideally, that should be out of sight from anybody else. That way it doesn't distract. And that's about all they're there for. They're just maintaining all the patients that are not going to be leaving to get treatment. All right. So like it says, MCI we talked about definition wise, it's 3 or more patients, puts a large demand on there, and has the potential to cause multiple casualties. Very large incidences, major car wrecks, you know, 3, 4, 5 vehicles. Again, like I said, bombings, tornadoes, fires, multiple different things that can cause this. Most systems have their own protocol for when to decide when an MCI is. Like I said, with us, it's anything truly that we don't have the resources for. You just have to remember that we can't treat and transport everybody at the same time. That specific one, you can't just run in, realize, okay, this is an MCI, I'm going to call for help, grab a patient, and then take off. Like, there are other patients on scene, you cannot abandon them just because you take a critical patient. So realistically, when that first unit gets on scene, they are not going to put anybody in their ambulance until either A, somebody else comes in and takes over incident command, or the entire thing is done and over with. So if there's multiple patients, not enough resources to handle without abandoning it, you should, again, that's when we say, okay, this is an MCI event. We get on the radio, tell them, hey, we need help. We need 4 more ambulances. It's an MCI. I will be your incident command, and then send your EMT or your partner, whoever is low man on the totem pole for the day, to do triage. Like I said, we're sorting those patients out based on the severity of their injuries. It has to be quick. It's not going to be something where we're doing any kind of care. Again, this is done so that we can assess how many patients there are, how many we have a chance of rescuing, how many are able to walk away from this. Most of the time, everything's pretty standard for common categories. You've got your critical or immediate reds, delayed yellow, minor, that's your walking wounded, your greens, or black tags, which they're either dead or they're going to die. So there's your priorities and kind of typical injuries. Most time with red tags, it's they need active help right now. Like they need to have airway breathing control, uncontrolled bleeding, things that if we don't do something right now, they will end up being a black tag. Sometimes it's hard to differentiate between a red tag and a black tag. Again, it ends up being a judgment call. Most time, if you look at a patient and you know they're not going to get help in time, we're going to have to put a black tag on them. It's not fun. It's not something that we are comfortable with most of the time at all, and that's okay. But ideally, putting this stuff on the patients lets us track them. It helps keep a record of their condition, whether it gets worse or not. Most tags are very easily read, very simple, color-coded, kind of universal. That way, anybody who uses them knows exactly what they're showing. So there's start triage, simple triage, and rapid treatment. First step, we're going to say, hey, is anybody out there? Can you hear me? Tell them, if you can walk, I need you to go to this area. Those that get up and walk out and get to that spot are labeled green. Okay? They're good. And then the second step is going towards those patients that cannot get up and move around. That's where we start assessing, their breathing, whether or not they're bleeding out or anything, or if they're conscious. The difference with pediatrics, which we talked about during the pediatric lecture, is it's called Jumpstart. Kids 8 years or younger, or if they look like they weigh less than 100 pounds. Again, same thing, we're calling out, trying to get the walking wounded to up and out of the area so we can assess the other ones. With Jumpstart, when we're looking at patients, if these kids are not breathing, but they have a pulse, or if we just see that they're not breathing at all, we need to open their airway, give them a few breaths. If they start breathing, then we can red tag them. If not, then they're black tagged. So adults, we don't even waste time with breathing. If they're not breathing, they're not breathing. They're black tagged. Kids, we give them a chance. We give them that respiratory bump to see if it works. Like I said, if somebody's freaking out, they may be a hindrance to us. Okay, even if they're walking wounded, we may need to go ahead and have them addressed first. That way we can continue on with our assessments. Our first responder who becomes sick or injured obviously is going to be an immediate priority. Okay, we're going to get them out of there and get them taken care of. If it's a hazmat issue, we need to go ahead and identify who's contaminated, who's not, who's been decontaminated, and have the appropriate areas set up. All right. So destination decisions. It's going to be kind of a figure out who has the availability. Reds and yellows ideally should be transported by air or by ground ambulance. If we can get a bus to transport the greens, fantastic. It makes it even better. Again, they're walking wounded. They have very minimal injuries. If we can get them out en masse, perfect. If we can, we need to always try to double up patients, because again, this is a high level, high patient count incident. We may not have the benefit of just taking one patient and worrying about them. Again, we're trying to do the most amount of good for the most amount of people. So we'll probably end up taking 2 reds, or a red and a yellow, or 2 yellows. It just depends on, again, the resources we have. All right. So then the patients delayed category, like we said, we can kind of double them up, put a few in there and go. And then the last ones to be transported will be the walking wounded, because again, they're okay. They have minor injuries. At the very end of it, the black tags, dead victims, they're going to be handled however that standard operating procedure is for the area. Most time that's with law enforcement interaction. We just need to confirm what we need to do on our side of things for that. Just like anything else, most time when a patient is dead on the ground and we haven't done anything for them in this kind of instance, we're not going to transport them anywhere. Destination decision wise, anytime we do this, we always need to notify the hospitals early. A lot of times when we get on the radio and declare it as an MCI, we let dispatch know, hey, go ahead and let the hospitals know they're fixing to have a massive influx of patients. Usually what they'll do is they'll notify them, and the hospital will tell us how many patients they can handle or think they can handle. And we kind of base our transportation decisions on those. Some of them may be going to areas farther out than here. You know, if you're here in Tyler and we have a major incident, most of ours are going to go to Mother Francis and Tyler. Some of them may get pushed out to Jacksonville or to Athens or Quitman. It just depends on who's available and who's able to support these patients. Right. So again, disasters, that widespread event, think of tornadoes, things like that. It mucks with the entire function of the community. Not only does it threaten lives, it threatens property, houses, buildings, businesses. So just be aware of that. And again, floods, fires, hurricanes, they may not cause personal injuries per se, but they do cause widespread problems. And our role is to respond to whatever incident command has assigned us to. Casualty collection area may be set up. They may have a designated area for where we put those black tags. Again, this is going to be set up through incident command, just like, you know, the EMS branch or the fire branch, law enforcement branch. All that will be set up the same way. That's one reason why NIMS is so good. It keeps everything uniform. Hazmat wise, if we're first, for one, we need to make sure we assess the whole scene survey, make sure we're safe. Again, because we don't want to rush in there and get caught up in it. because for one, we can't help anybody else out there now because we've been exposed and now we're injured or contaminated or dying. And now we put an even bigger strain on the next crew that comes out there. All right, so according to the HAZWIPR agency, first responders at the awareness level should have sufficient training and demonstrate the following: and a general understanding of what hazardous substances there are and the risks with them and the potential outcomes from those incidents. Combine that with the, like the pocket field guide for hazardous materials, and you'll be able to figure out what kind of things are out there, what you may encounter. A couple different areas of training. For one, the ability to recognize the presence of those substances. How do we know they're there? Well, there's this big old green gas being emitted, or there's a yellow fog covering the area, or it smells weird. An understanding of what we're supposed to do and how to determine the need for additional resources and who to notify. Those are a couple different things that we should know at the awareness level. Again, with this stuff, we need to be aware that most people are not used to handling this stuff. It poses a humongous risk if it's not taken care of right, stored right. And we need to make sure we look everywhere. Again, that's part of your scene survey, that windshield assessment. Again, critical visual indicators. Are there 50 people laying on the ground, passed out? Is there a fog over the ground? Is there some kind of odd smell? All these types of things will help us recognize that there is some kind of material here that we don't need to be getting into. A couple different situations where you might find this stuff: trucks, train crashes that were carrying stuff, industrial plants, natural gas pipes. All those things can have potential hazardous materials that can affect us. A couple more: you've got your underground fuel tanks, waste decomp from sewers, building up methane gas, or just a simple MVC that has a ruptured gas tank. All those can cause significant problems with hazardous waste or hazardous materials. Occupancy location: we know quite a few different chemicals are stored all kinds of places. Is it extremely hazardous waste? Where is it normally stored? Is it stored underground? Is it stored in a shed? All this stuff can be placed in multiple different types of containers. Like I says, our sight and our hearing are two of our most important things. Like I said, if we see fog over the ground, we see a bunch of people laying out, probably a red flag. And using any of the senses that can bring you in proximity to that chemical, like your sense of touch, your sense of taste, obviously we shouldn't be doing that. You're not going to go licking all these containers, right? Container does hold something, hold some kind of material. Most of the time these are important, and they show visual clues as to what is inside that container. You got two categories. You got your bulk and non-bulk. Again, bulk is many, a lot. Non-bulk is the opposite. Container volume: bulk storage containers found in buildings that need to store large quantities. Industrial plants are going to be a pretty good indicator of these. Most of these have some kind of secondary containment. There's a little kind of picture of them. So we've got our containers there. And then technically we've got a secondary containment with that fence behind it. Here's another one. So that's an intermodal tank. These are totes. Again, it looks like there's a fence back there, so some kind of secondary barrier. Non-bulk storage vessels, drums, bags, carboy cylinders. All of these things have to be labeled. Okay. So just be aware, anything that kind of looks like it could hold something, assume it has something potentially hazardous. Labels, placards, and other markings. Again, that field emergency field response guide, fantastic for this. Okay, will help teach you about these hazardous materials. They have, they're diamond shaped. If you've ever driven behind an 18-wheeler, you've probably seen one. They're supposed to be set up in a way that you can see it from a distance and see how it would affect you, what number the chemical is or material is, and if it reacts with anything. And labels are just smaller versions of that. So there's a couple different ones right there. Again, they're usually fairly large, and they have fairly simple symbols on them. Because 3 of those we can look at right now and tell, okay, this can catch on fire. So there's your warning labels right there. Again, if you have never looked in the emergency field response guide, I encourage you to do so. It's also available online or as an app. Underutilized, in my opinion. So the DOT does not require that all chemical shipments be marked. Some chemicals are so hazardous that the shipping of any amount, whether it's a large amount or even just a very, very tiny amount, has to have some kind of label or placard to it. Just be aware that you may have to ask whoever is there, available, what is contained in some of these containers. Like I said, that field response guide, very successful, very useful tool. Like I said, it's 4,000 different chemicals in there. It's continually updated every 3 to 4 years. So realistically, it should be updated this year. Material safety data sheets. These give us the information about what the chemical makeup is, kind of hazards it may be, first aid if you do have an exposure to it, and any other items for safe handling. So if you cannot find information on it, always ask the supervisor at the chemical plant or the industrial place or the safety officer, hey, I need to see your safety data sheets for this. Shipping papers are required whenever materials are transported. So it's got the names and addresses on there, the name of the material, and how much, and the weight of each part. So these papers for the road and highway are called bills of landing or freight bills, and they're pretty much always located in the cab of the truck, wherever vehicle is transporting that stuff. So Chemical Transportation Emergency Center, Chemtrec. It's a good resource for us when we need to talk to somebody about these chemical incidents. Kind of like poison control, we can call Chemtrec and they can tell us information about this stuff. They can pretty much have, when we call them, we need to at least have the name of the chemical. So identification can still be difficult. If you look right there, what it's telling you is if you see any of that stuff, it's probably not good for you, right? So if you see a cloud or some smoke, or leak or spill or some kind of strong odor, those are red flags for anybody. Because the downside is some people are dishonest. They may not label things correctly to get out of certain fees, certain issues. So we always run into the possibility that whatever they tell us or whatever is on that placard may not be what's actually there. If we think there is a hazmat incident, we always park again upwind, uphill, out of the way. Don't re-enter scene. Don't leave the area until you've been cleared or decontaminated. Try to avoid any contact with said materials. Like we said, if you get there and there's more than one or two people laid out in respiratory distress, unconscious, go ahead and assume that there is some kind of hazmat issue going on. We do have a PA system in our ambulance. As long as it works, use it. Let everybody know in the area, hey, there's some kind of hazmat problem here. Get away from this area. That way we don't have more patients. Establish those zones. You've got your hot zone where everything's happening, your warm zone, your cold zone. Make sure we put our command further away. We don't want to be probably in the warm zone. We want to be on the outside so we can maintain the situation. And at the same time, we need to be ready to make it bigger. If we catch a wind and it starts blowing it towards us, we need to be able to pack up and move further out. If not, if it starts getting contained, we can move inward. So again, that hot zone is where everything is right near that contaminated material. Warm zone is going to be where we're going in and out of the cold zone and the hot zone, just that kind of in-between space. You'll be wearing your protective gear there. Cold zone, you don't need to wear special protective clothing to operate. Again, we're far enough out that we don't have to worry about it. Hazmat-wise, as the EMT, your job is to report it. We're going to, again, do triage, treatment, transport, and rehab, depending on what role you are assigned to. The hazardous materials classification standard, you have your health hazard or toxics, your fire hazard, chemical reactives, and special hazards. Toxicity levels measures how much of a health risk a substance is to whoever comes into contact. And obviously, the higher that number is, the higher toxicity it's going to be. So 0 to 4, again, depending on what it is, depends on how much protection you need. Obviously, 3 and 4 are extremely significant. Most of those you will need to have specialized training. PPE, your level A, that's the most hazardous. That's your fully encapsulated chemical resistant clothing. There's nothing that can get to you. You have full body protection, completely sealed in. Level B is a little bit less than that. Does require a breathing device and eye protection. Level C is non-permeable clothing and eye protection, face mask that filters all inhaled outside air. And then level D is the one that's the minimal protection. All of these you will have gloves on. So there's your 4 different levels. So clearly you can tell from level A that they are way more protected than that guy at level D. So again, it all depends on what that chemical is and how toxic it may be. Caring for patients, it's practical to provide the simplest assessment. Again, we're not trying to contaminate ourselves or make things worse or tax the system. So We also may have this big gear on. We may not be able to do very fine motor skill things. We may not be able to put in an OPA because we have massive gloves on. We're looking at two things: trauma from the injury, whether it was an explosion, fire, or anything from a exposure to toxic substances. Those are our two main things. Again, most serious injuries and deaths from hazardous materials will result from, again, airway and breathing. If we don't have an airway, if they're not breathing, they're going to die. We have to be able to breathe. Sometimes the hazmat team may come across people that need immediate treatment before the decontamination area is set up. If that happens, you may end up treating those patients before decon is set up, which would result in you having to decon as well. Again, if you're going to treat these patients, we've got to have the proper protection. CBA, 2 pairs of gloves, goggles, protective coat, breathing protection, and an apron. A lot of this stuff looks kind of similar to what we're using for coronavirus, right? Just have to make sure that we're well protected. Because again, if we're exposed and we have something happen to us, then we can't help anybody else. When we put these patients into the ambulances, we have to make sure that we turn on that vent, the exhaust vent. That way we're not having that constantly recirculate in there and affect us. Super important to tell the hospitals on the way that the patient we have is not completely decontaminated and what they've been exposed to. That way, if they need to address the issue, they can set up a decon area right when we get there. All right. A bit of review. What's the purpose of the incident command system?
D.
Yeah, I do all those. We want to make sure we're safe, the public's safe, make sure we meet those management goals for assessing the situation and using our resources to the best of our abilities for the most good for the most amount of people. Right. Dang it. Went too far. Upon arriving at the scene in which the incident command system has been activated, you should expect to what?
D.
B,
A. Yeah, A.
Yes, this one's a little bit harder. You got to kind of look at the answers a little bit. It's going to end up being A. You're going to be, you'll initially report to them when we get there. Between assignments, depending on what resources are needed, you may be moved different sections. Again, that goes with the demobilizing and changing what services we may need. You may initially start out in the treatment sector, but as we continue treating patients and we have more to be transported, we may be shifted into the transportation sector. So when EMS responds to a disaster as part of their response, the ICS, they would start the scene size up. What is the next step for the first responding units? So we started our scene size up. What do we do next?
B.
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 Yeah.
B.
we're going to set that command up. Again, we're first on scene, so we need to let them know, okay, we are command until otherwise noted. All right, so which of the following statements best describes a mass casualty event?
D.
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 Yeah. We have more patients than we have resources. All right. So which of the following patients would have the highest treatment priority at the scene of an MCI?
A.
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 Yeah, because if you look at it, everybody else isn't breathing or doesn't have a pulse. This patient still is breathing, so they're labeled critical. Everybody else is probably going to be labeled a black tag because they're going to have severe traumatic injuries and they're pulseless. How does a disaster differ from a mass casualty event? So think about current things that have been going on in the world right now.
D.
A.
So it is actually going to be D. So disaster-wise, just like, Governor Abbott declared a disaster for coronavirus, and we've been dealing with it for weeks on end. It's all of those. So it may not involve personal injuries, just like coronavirus, for example. We may be on scene for days or weeks at a time trying to take care of this. All right. So large tanker truck is overturned on a highway. When you arrive, you see a clear liquid leaking from the rear. The driver appears to be unconscious, is still in the vehicle, and is bleeding heavily from the face. You should do what? We've got immediately notify law enforcement and traffic control, fully assess the situation, and request the appropriate assistance. Put on gloves, a gown, a mask, and quickly remove the driver, or go to the rear of the tanker and determine what type of fuel is leaking. Bounce back to the other two.
B.
B.
Yeah, that kind of goes with our scene size up, right? We want to make sure that we know what we're getting ourselves into. Obviously, if something's leaking, if we don't know what it is, we need to find somebody who does. All right, so which of the following situations most likely involves a hazardous material?
B.
B.
A.
A.
D. A.
Everybody's picked everything.
It might be sour.
No, that's right.
That tractor trailer is emitting a cloud, so that's something obvious. Everything else, the milk truck overturn is leaking fluid. Well, it may just be milk. Again, you're right. We don't necessarily know.
Could be sour.
Milk is classified as a hazardous material.
Well, I personally am worry more about that trailer rig that's got a cloud coming out of it.
Unless it's almond milk, then it's okay.
All right. When dealing with a hazardous materials incident, where should you set up your decontamination area?
C.
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 B.
All right. So it's going to be C. We want to do it between that hazard zone and the treatment area because we don't want to have them contaminated inside the treatment area, then it's going to be a contaminated zone. So when we're pulling them out of that hot zone, we'll decontaminate and get them into that treatment area. So which toxicity level would you assign a hazardous material spill that could cause a person temporary damage or residual injury unless prompt medical treatment is given? So that sounds kind of, yeah, that sounds kind of bad, but is it necessarily super bad?
B.
B.
So it's going to be level 2. Those ones that if we don't get them taken care of now, they may end up having effects that last for a long time. All right.